Thank you guys for joining us today. Today is our first of our quarterly swing bed webinar series for this grant year. We have Lindsay from Stroudwater presenting over Swing Bed 101. It's kind of our kickoff webinar. As I mentioned, it will be recorded. We will be posting this on our YouTube channel for you to view at a later time, or if you have new staff joining your facility. We are a smaller group that's growing in numbers by the minute, but thank you all for joining us. But if you have any questions at all, you have control over your microphone, so please feel free to unmute, just ask your question, or if you want to put it in the chat, I'll be watching the chat. We want this to be as interactive and as helpful as possible. So with that said, Lindsay, I will turn it over to you.
Hey, thanks everyone. Thanks Laura for having me. So today's webinar is really just a kind of high-level overview of swing beds. Maybe it's an opportunity for some new staff to hear about some regulations related to swing beds. Maybe it's you're a seasoned staff member and you just want to make sure that you are in compliance, and maybe it's an opportunity to kind of check your policies and procedures to make sure that you are in line with kind of what's going on related to swing beds. So I'll jump right in with today's agenda. Moving forward. Okay, good. So we're just going to talk a little bit about, really the value proposition around swing beds. Why are they such an important aspect to our rural hospitals? Provide some overview and background related to swing bed, jump into some regulations and requirements. If we have time, I've included a few slides related to skilled care. That's always something that is certainly kind of a hot topic. So if we do have some time, I can certainly share those with you. These slides are, not data rich, but rich with lots of information. So they will be available to you all. And I always preface that because there are times where I often have to go back and reference what I've included in slide decks to make sure that I'm up to date with this information. So, and again, as Laura said, feel free to use the chat for any questions and answers. If I cannot answer any of the questions, or maybe a few of the questions, I will make sure that I'll answer the questions in follow-up emails back out to the group. That seems to have worked in the past when questions have come from the group. So, all right. So, why swing beds? And this may be all different for your organization and why you have pursued and operate swing beds in your hospitals. But really, there's a opportunity for increased access to services for patients. They can't be acute any longer, and they can't go home. So there is a place for these patients, and that is in our swing beds. There's a financial benefit to hospitals. As a critical access hospital, Medicare reimbursed swing beds at cost-based, so 101% of reasonable cost. And it also helps to comply with the critical access hospital 96-hour length of stay. So there's been plenty of studies done related to the quality of care, compared to a skilled nursing facility. Patients are able to stay within their communities and stay local. I was just working with a IHS facility in Arizona, and they're looking at adding swing bed services to their hospital. And, they have had a lot of patients that they will refer out to skilled nursing facilities that actually will not go because they don't want to leave their community. So again, it's very important, this allows, patients to really remain in their community and not having to transfer to an outside skilled nursing facility that may be miles and miles away. And being connected to your community, it's easier for your family and friends to be involved in your care and your visits. Obviously, some of these bullets are COVID, not COVID friendly. So we just, obviously everyone has their kind of responsibilities around COVID as well, and visitation and whatnot. And then, there's also the quality of care due to the skill mix of your staff and the access of services that a hospital provides versus a skilled nursing facility. And then, providers are actually less reluctant to discharge patients to skilled care when they're to skilled level when they're in-house. So, they're really looking to really continue that care of that patient. I just want to make a note, there's no requirement that a patient must go to a skilled nursing facility if there is a bed available. So even if you may have skilled nursing facilities in your community and they are not at capacity and have beds available, patients are not required to fill those beds. They can go to your critical access hospital swing bed. In addition, providers have a little bit extra time when they're, potentially maybe in-house to craft and hone in that discharge plan. There are, certainly improvements in readmission and avoidable ED visits when we leverage the swing bed program for our patients. And then, the average length of stay, typically, certainly depending on patient status, is around 10 to 12 days. And that is noted to be much shorter than skilled nursing facilities. So it certainly, and there is no restriction on length of stay. So if your patient exceeds that average, that is okay. If they're in there for 5 days, that is okay as well. And then a robust swing bed program can certainly be beneficial for both you and your referral sources. Certainly, I'm going to talk about in the next slide on the importance of swing beds during COVID and how referral sources really have looked to hospitals with swing bed programs to really help lessen the burden and their capacity issues. So as I mentioned, the importance of swing beds during COVID. Hospitals have this existing infrastructure to really address both acute and skilled care needs, and that's different than in skilled nursing facilities. Specific to COVID in the importance of infection control and the ability to care for more complex patients. So, if you have a patient that is going south, you have that, in-house emergency care, or potentially maybe you have IC level care if needed, the 24 access to nurses and to providers. And then, as I mentioned before, really around the bed capacity, where during, certain heightened surges or whatnot of COVID, some of our rural hospitals were not at capacity. And so that was certainly an opportunity, and still remains an opportunity, to really work with our referral sources to help support those needs in capacity. And at the same time, some SNFs were not accepting patients or new admissions. But there are certainly, with all of the pluses related to swing beds, there are certainly some obstacles that you may be facing within your own swing bed program, such as the amount of paperwork or documentation that often is associated with swing beds. As I mentioned before, really around the skilled need, and that ties back to the documentation, is how do you document for meeting that skill need? Is that patient meeting the skilled need to continue being in a swing bed? That certainly is a potential barrier. And volume. We have some low volume hospitals that certainly have the capacity to support lots of swing bed patients, but then we also have high volume acute hospitals that although they offer swing beds, they are also, very capacity constrained. So we want to, certainly volume can play both sides of the coin. All right. So a little bit of background around the swing bed program. So since you all are critical access hospitals, a lot of this information is directed at critical access hospitals. And so the swing bed program has, is regulated by CMS. And so there are various requirements related to CMS that hospitals must meet, including conditions of participation. And we're going to walk through that conditions of participation in just a moment. General eligibility criteria of a patient. So if you have a Medicare patient and you must meet the following criteria. So that patient must be a Medicare enrollee and have benefit days available. Just because I'm talking about Medicare doesn't mean that you only can accept Medicare patients into your swing beds. You can accept Medicaid and commercial payers, but the payment for those swing bed services for those different payers may be different. A lot of times Medicaid and the other commercial payers may have specific requirements, or they may, and it really could depend on states too. So other states, other state Medicaids may have different requirements for swing bed services. So it's very important to make sure that, during your pre-admission process that you are checking payer requirements and payments. A Medicare patient must have a 3-day qualifying stay. So they have to have a 3-night stay as either an inpatient in your own critical access hospital or another, hospital or hospitals. Observation and ED stays are considered outpatient. So those, if they had one night stay as an observation and then 2 nights as an acute, they would not meet that 3-day qualifying stay. But, as you know, that we do have the waiver related to the public health emergency. So that is waiving that 3-night stay currently. And so that is not applying as of right now. But just, if we were not in the public health emergency, certainly we would need to meet that 3-day stay. The patient must be of Medicare age or have a disability or disease that allows them to participate in Medicare. The patient's swing bed admission condition is the same as their qualifying stay. So whatever they were in their acute hospital stay should be their admission condition to the swing bed program. And then a patient admitted to swing bed, it has to be within 30 days of discharge. And again, the patient's condition meets skilled nursing criteria, whether it's rehab or a combination of skilled nursing and rehab. And as I said before, there are no length of stay restrictions. So as long as a patient is meeting that skilled need, they are able to still stay as a swing bed patient in your hospital. Some information around payment. So Medicare patients do have a copay after they reach 20 days in swing bed. And it's in the 2021 payment copay per day is around $185. And then once a patient exceeds 100 days, then the patient is responsible for 100% of the cost of services in swing bed. As you probably know, a lot of Medicare patients have supplemental, insurance that tends to cover that copay. Again, these are items that you would make sure that you understand prior to admitting a patient into your swing bed program. So what are some of the types of swing bed services, that are currently offered? We certainly have the rehab therapy component. So whether your program offers all three of these services or just physical therapy, many hospitals offer wound care or IV antibiotics, medication management, and there's certainly a lot of teaching and training activities, whether those around teaching how to self-administer, a diabetic patient's insulin, or medical gases. If a patient is post-op amputee, how is there gait training or care of the patient after some type of ileostomy. So certainly lots of different types of swing bed services provided. Is there, I don't know if you'd like to include in the chat or take yourself off of mute, any other types of care, not listed here that is being provided in your swing bed program?
Lindsay, this is Laura. I'm not seeing anything in the chat right now either.
Okay. All right.
Lindsay, this pretty well covers it all for O'Keene.
Okay. Thanks, Emily.
Mm-hmm.
All right. So I wanted to include just high level looking at the admission process. And certainly that starts even before a patient is in our swing bed. And so, when a referral is made or a referral is received, this whole pre-admission process includes, checking for the patient for medical necessity, starting to incorporate and leverage your interdisciplinary team. And I know that in previous webinars, we've really talked about the interdisciplinary team and who's involved and what are their roles and responsibilities, but such an important aspect as it relates to swing beds, as well as any of our acute patients. Understanding what the patient's needs are, whether it's medications, equipment needs, services needed while in the program. If there's any pre-authorizations, again, as I mentioned before, making sure that you're checking the various payers and what their requirements are. And most importantly, involving the patient and the family. Start to have the conversation, answer questions related to what swing bed services include and what the patient and family can expect as they come to your facility for swing bed services. And then at admission, so you want to make sure that we have that discharge order from the acute stay. And that is obviously the discharge order either from a hospital, another hospital, or your own facility. I do want to make a note that we want to make sure that there's still that choice, that patient choice that they have. So say if your patient is at a referring facility, that referring facility is giving this patient a patient choice for post-acute providers. And we want to make sure, and it's very important, that your swing bed program is on that list of choices for post-acute care services. So again, just keep that in mind, and that you want to make sure that that's on there. Admission order into the swing bed program, new or updated H&P, as well as information relate for the patient, and that has to be said to the patient, verbalized, confirmed with signatures, include the physician choice. We're going to go into that in just a moment. And then again, incorporating that interdisciplinary team and conducting kind of an admission assessment that's really going to flow into the comprehensive assessment and care plan. And one item I'd like to note is around quality. And again, as I mentioned before, the making sure that your swing bed program is on the choice list for post-acute providers at referring hospitals, and looking at how we leverage performance and quality of our swing bed program, and start to incorporate these quality metrics. And so internally, is there a way that we can start to track these percentages? Maybe it's, can we track and start to publish or promote our discharge to community? How many patients, swing bed patients, are discharged back home? What a great statistic that is, that we are getting patients returning to home. So again, it's just something to consider as you continue to promote and grow your swing bed programs. And then lastly, around the discharge process, certainly there's an order for discharge. The discharge notice is provided to the patient as soon as that discharge is known. So it's not, right before the patient is to be returned to home and a car is supposed to pick them up. This is as we are planning the discharge, there's a notice to the patient. Including in a discharge summary, you have the summary of the patient's stay, medications, and then the plan of care post-discharge. So again, if there needs to be a transfer, that certainly has an additional process required. Okay. So a little bit about the regulations and requirements. And what we're going to focus on is the critical access hospitals and the section really pertaining to swing bed services. And so there has been some updates and rule regulation changes. So we had revised rules in 2018. There were changes in 2019. And then there was a new set of published rules in 2020 for the conditions of participation for swing beds. So there are these three sources here are certainly good ones to reference for your swing bed program. But we're going to focus on the conditions of participation out of the Appendix W. So high level, here are the conditions of participation for critical access hospital swing beds. So we are going to dive into all of these here. And these are really the requirements that a CA must comply with. So certainly important to pay attention to. Some are related very specifically to patients, so mostly like the patient's rights. And some are very program specific. So, certainly, about rehab services, that is program specific. When we're going to look at patient rights, and then I'm going to highlight just a few. There are lots of patients' rights that are included in the conditions of participation. So I'm not going to go into all of them, but I will highlight certainly a few of them. A patient has the right to dignified existence, self-determination, and communication. This is and all of this is very important because the patient's rights must be in a language that the patient can understand. And so again, you really, not only should we be focusing on the language and that our documents are in in a language the patient understands, but we have to make sure that we're incorporating culture and cognition into these documents that we are providing and for around the patient's rights. So certainly making sure that we address any communication problems, whether we need to include an interpreter, or there's hearing problems or cognition limits. Again, we just make sure that those are incorporated into this process, this policy. So let me just go back one more. So making sure that the patient understands their health status. And so really, what does health status include? And it's certainly this whole list of, their functional status, nutritional status, cognitive status. And again, this must be communicated in a language that they understand. We want to minimize, technical words, and provide the interpreters, any sign language. Again, just something that's easy to understand, and bring in other interventions as appropriate. So as a patient has the right to accept treatment and understand what their treatment is, they also have the right to refuse treatment. So let's see, sorry, I was just looking at the chat. Treatment is really looking at maintaining or restoring health, improving functional level, and relieving symptoms. There's also, they can refuse to participate in experimental research, and the right to refuse a advanced directive. And we have some more, I think, of my next slides on advanced directives. So they do have the right to refuse, although we know, there is certainly some importance related to advanced directive. The patient does have the right to refuse. And then, so related to advanced directives, we want to make sure that we have policies and procedures that really call out advanced directives. So we want to make sure that we're documenting in the patient's record that they have an executed advanced directive. And then if they don't, and also document if they don't as well. We want to ensure that we're compliant with any state laws, as well as educate internally our staff around policies and procedures related to advanced directives, and then community education. I know that when, excuse me, when I go to my doctor's office, they have, a TV, and on the TV is, some information around the practice, as well as, hey, have you filled out your advanced directive? Do we have one on file? So it's certainly something that's, certainly in front of us. And then a patient has the right for a free choice, and free choice meaning that they have the right to choose a physician. And that, so it's really important that we present a list of available physicians to our patients. So maybe your patient does not have a physician. And so we need to make sure that we assist the patient in really finding a physician. One that has swing bed admitting privileges is very important, but they do have that choice to choose their own physician. And patients' rights around person-centered care, so really around the planning and treatment of their own care. And this, falls into the comprehensive assessment that has to be done, really related to the facility's timelines. It also includes the assessment of trauma. But what we'd like to see and what we recommend is that comprehensive assessment is done within 24 to 48 hours of admission. And then is anyone's done longer than that? And if so, outside that 24 to 48 hours, what is the barrier that may exist that prevents you to get to that 24 to 48 hours? So if you want to put that in the chat. The other thing is again, the involving the patient, the family, or the caregiver in that care planning is certainly important in making sure that we document any type of refusal of treatment. And certainly that is documented, and they do have that right. And then privacy and confidentiality. So certainly the patient has the right to privacy and confidentiality of their own selves and their records. So we should be making sure that we have policies and procedures, and our actions are that we really treat patients and provide patients with whether it's, privacy curtains, or making sure that we are draping patients and letting them have the space that they need to, use the bathroom. Certainly we need to make sure that we are exercising the privacy and the patient's wishes related to privacy and confidentiality. And something that you may not have read in the conditions of participation, but certainly exist and want to highlight, but patients have right to privacy and written communication. So they have the right to send and receive mail that's unopened. They can have access to stationery and postage, certainly at their own expense, but something that they should be able to have access to. Visitation needs, again, COVID and the restrictions on visitation, but in non-COVID times, they're setting facilities needing to set reasonable hours for visitation, and encouraging patients to kind of bring personal possessions to the facility as well, within obviously the requirements or the set forth by the facility. Okay, so moving from some of the examples of patients' rights, there is a conditions of participation related to admission, transfer, and discharge. So this intent here is around the transfer and discharge, is that once a patient has been admitted to the hospital, these regulations or requirements are to really avoid any type of patient dumping. And I hate to use that term, but they would not be, a regulation or a requirement if this didn't exist. So we need to make sure that we follow the transfer and discharge policies and have those outlined in our organization. But a transfer may happen of your swing bed patient if there's a significant change in the patient's condition. And so with that, what is a significant change? A significant change could be the deterioration of 2 or more ADLs. So, it could be a patient had a stroke and has significantly deteriorated because of that stroke, or the loss of ability to ambulate or use their hands to grasp or to feed or groom, the deterioration in behavior or mood. You could have a dementia patient that may be very combative, and that is placing, staff and other patients in danger. That could be a significant change that would require potentially a transfer. Deterioration in the residents or the patient's health status. So again, certainly, something like a stroke could be significant pressure sores or some serious complication that has occurred that may require a transfer. So if there is a transfer or a discharge, there's certainly notifications and documentation that are required. Physician documentation to the transferring facility and where that patient's going. So what must be included is certainly the information of the provider and who was responsible for the care of the patient. What is their at-home representative, if they have advance directive, any special instructions or precautions for ongoing care, the developed comprehensive care plan, as well as a discharge summary, are really some of the key components of what needs to be documented and sent for a transferred patient. So another condition of participation is around freedom from abuse, neglect, and exploitation. So it's really the hospital's responsibility for preventing patient abuse and how to report abuse, and making sure that all staff understand how they can report abuse and neglect internally, as well as report any type of abuse that happens externally. So very important to make sure that you are reviewing your policy. There was an update, and I've highlighted it here, in terms of the timeline of reporting any type of abuse, neglect, and that the timeline is now 2 hours, no later than 2 hours after an allegation is made. So again, making sure you're educating your staff and having those written policies related to abuse, neglect, and exploitation. So certainly a program-specific condition of participation is around activities. So your facility really must have, part of the comprehensive care plan and assessment, there needs to be some type of assessment done around activities and understanding what is going to be an activity for the patient specific, whether it's an independent activity or a facility group activity, but really taking into consideration the interest of the patient and whether or not it supports their physical, mental, and psychosocial well-being. So again, looking at your nursing care plan, are you including a psychosocial assessment as part of your care plan? And when we think of a question that often comes up is, well, we don't have a activities coordinator at our hospital to facilitate activities for our swing bed patients. Well, the language within the conditions of participation is around a qualified professional. And that could be an activities director, a therapeutic recreation specialist, an occupational therapist, or any other professional with experience or education in recreational therapy. So there's certainly some, doesn't need to necessarily be an activities director. And I did want to take a moment to talk about when I mentioned the psychosocial assessment and how that gets incorporated into our care plan. And one of those is around trauma-informed care. And so the goal around trauma-informed care is to eliminate or to really decrease the number of triggers or any type of trigger of trauma for the patient. It needs to be, culturally competent, in accordance with professional standards of practice, and really accounts for patients' experiences and preferences. So as part of, looking at your psychosocial assessment, is it taking into consideration trauma-informed care? And, there's trauma-informed services, and, those services or maybe they're interventions that really are targeted to help patients and families coping with any type of trauma strategies and to cope and process trauma. Again, trauma-informed care is not a mental health intervention. It's really a commitment to bring forth, change in the organization on how, we provide patient-centered care. And so some key questions that, you all should be asking yourself related to our hospital's practices and whether or not we are providing trauma-informed care. So, do we promote clients' physical and emotional safety? Do we maximize and build clients' trust? Do we have tasks that are clear and enforce appropriate boundaries? Again, do we enhance clients' consumer choice and control? Do we maximize opportunities to collaborate with clients and share power and decision-making? And do we prioritize clients' skill building at every opportunity, really around that empowerment? So if you want, and maybe, this is always an opportunity to share some learnings from other folks, because it's, isn't probably certainly not talked a lot, but how does your organization provide trauma-informed care? Is there something that you've specifically done at your organization to incorporate that into your practice? Again, you use the chat or feel free to take yourself off of mute.
Hi, Lindsay, this is Laura. I'm not seeing any questions or comments regarding the trauma-informed care.
Okay.
But we have received a couple questions. I don't know if this would be a good time to jump in or wait till the end.
We can certainly jump in. Yeah.
Sorry. One of them, going back to the patient's rights and responsibilities, Emily and O'Keen wanted to throw a question out to the group. If anyone has any written policies that they would like to share. She has one that she's willing to share, but would like to just compare to see what other folks include in theirs. And Lindsay, do you have a sample as well?
I think I do.
Okay.
So let me write that down.
Okay.
And I will, when I send out the slide deck to you, Laura, I'll make sure that that's included in there.
Okay. And then Casey, oh, go ahead.
Oh, and that's the thing is, like, if you, I think that's a great question, Emily, and because really around policies and procedures, there's no reason that anyone should be recreating something. When, the policies and procedures are the policies and procedures. They may be different tweaks to your organization that you can certainly go in and change and make and update. But for the most part, the meat and potatoes, if you will, of it is all the same. So certainly sharing, policies and procedures is great. So happy to help if there's something that you're missing or you'd like to just compare to what you have. I can certainly dig through files and find stuff for you.
That's great. And I'll send it out to the group as well.
Okay.
Next, Casey and Hilton asked, can we get some assistance on finding some information about certified activities director programs to share with their coworkers?
Are you talking about like training programs?
Yes, we at one time, can you hear me?
Yeah.
Yes.
We had found an activities director course for coworkers to go through, and we sent a couple at that time. but we've had turnover since then, and we'd like to get a couple of more. That's one area of improvement that we have is beefing up those activities.
Yep.
I didn't know if the state did some kind of activities director class. The way where we went through last time is not available anymore.
Laura, do you know if there's anything at the state level? I mean, I think that's something we can certainly check out because, as you know, your staff just has to be educated, have some sort of certification to be able to do the activities.
Yes, and they got a neat little plaque that naming them as activity director and.
Yeah, that's great. Okay, so I'm going to write it down as well. I'm sure Laura can check into it from the state perspective.
Hey, Lindsay.
Yeah.
When they did the update on the conditions of participation,
Mhm.
they did away with having to have an activities program because the length of stay was less than, I don't remember. I mean, it was a shorter time.
Like
But
5 days or something.
I think it was less than 2 weeks. They did away with that. So we took that out of our policy on having to do an activities assessment and provide an activities program.
Yeah, so it's very loose. Like it's not having like a structured program and doing an assessment. It's more of providing, finding out some type of enrichment for a patient. And so whether that is, a connecting them with another patient or, doing something that's going to improve their physical, mental status. Does that make sense?
Yeah. And we offer that, but we
Yeah.
don't have it in our policy any longer. Is that, that should be okay, right?
I think so, but let me check.
Okay.
Because I know I do have a dated activities policy,
Okay.
but I will see if we have anything else.
Okay. Thank you.
Yeah. Okay. And okay, so I know I have 10 more minutes or so, and I do have a few more little conditions of participation to go through. All right, so certainly social services being one, and the requirement around providing medically related social services. So again, this is actually, it sort of relates to the activities. You don't need to have a social worker, but you need to be providing medically related social services. So really, what does that mean? And so it really means that, the facilities staff can assist patients in really attaining or maintaining their mental or psychosocial health. And so that could be around, advocating for the patients, supporting those patients' rights that we were just talking about, communicating the patient's needs, and looking at, assisting in transitions of care, making referrals to community or outside of the hospital. And I want to highlight, this is really an important part for an organization is to really start to develop their community kind of integration in their, what are the resources that are out in the community? What are going to help support our patients' needs when they are discharged from the hospital? A lot of times transportation comes up a lot. What are their needs as it relates to when they go home, and do they have, is there a home assessment that can be done? Can we make that referral for that to happen? So again, those providing those medical related social services is required and a responsibility for the organization. And then looking at, sorry, this slide's pretty busy, but looking at the comprehensive care plan and the comprehensive assessment, to be done really by each discipline of your interdisciplinary team. So, what is it for, PT and OT and dietary and respiratory therapy? What are their specific plans and their treatment plans that'll get incorporated into the nursing care plan for your patients? And we want to make sure that we are, assessing the psychosocial needs, doing a trauma assessment, if you have that available. And I'm actually going, does anyone actually have a trauma assessment or a form that you use, something built in your EHR? I don't know if I have. I'm just writing that down, sorry.
We do at Mercy. It's just part of, any patient that we see, whether it be ED, inpatient, sling, outpatient, whatever it is, just some straightforward questions such as, is this encounter related to abuse, or, and then your straightforward suicide questions and stuff, but not as far as like getting into childhood trauma, those kind of things.
Yeah. Okay. And that's built right into your EHR?
Yes, it's just a handful of questions. Like I said, it doesn't, get into triggers or your ACE scores or anything like that.
Yep. Okay. Let's see if there's a good example out there.
Lindsay, in the chat, Emily commented that they do not know Keen, but she's very interested if someone has one. If you have one to share, Lindsay, I'd love to send it out as well.
Yeah, I double starred that one. Whew, I got my work cut out for me.
We really appreciate it.
No. This is why we do this. I want, either whether it's connecting organizations with each other and you all with each other and sharing resources, or if I can be a resource, I certainly would love to do that. And then within the discharge summary, so making sure when we are discharging, we have basically the care of plan. We make sure that we're involving the patients prior to discharge, utilizing and leveraging the family and any preferences care. How will the care be done at home if the treatment is to continue? Who is there to kind of support that patient? And then any specific needs, whether it's, physical therapy at home or any type of caregiver education, that is included in that discharge summary. And then we have rehab services. So rehab service, if a patient requires rehab, but the facility does not provide, then the facility must either provide the service or obtain the service through an outside source. So if it's ordered that they need physical therapy, we need to, by the physician, that needs to be incorporated into their plan of care and be provided. There's also a condition of participation related to dental services, and hospitals are required to provide emergency care and dental care. So a lot of times we need to have the written policies and procedures around any emergencies or treatments or refusal for dental care if appropriate. A lot of times hospital or critical access hospitals have actually are currently addressing the dental care needs under the emergency services conditions of participation. So you just want to make sure that it is either in one of those areas, whether it's under your swing bed policies and procedures or the emergency services, or if it's referenced. Again, just double check there within your policies and procedures. And then lastly, high level condition of participation related to nutrition. And so this, includes a nutrition assessment, nutrition recommendations. Very important is to make sure that there is documentation related to hydration and hydration status. We want to make sure that our patients are within acceptable nutritional statuses as well. So, documenting body weight and protein levels. And if they need a therapeutic diet, making sure that we have somebody that is qualified to oversee dietary services. So again, important aspect, one of the conditions of participation for our swing bed patients is really related to nutrition and hydration. That I do have in the remaining couple minutes. I'd rather open it up to questions. I do have some slides related to skilled services, and what I'm going to do is incorporate those slides into our next webinar, which is set for February. And I'll make sure that I address, skilled nursing services and skilled nursing care, and go over some of the stickiness that's related to skilled care, because I know in feedback from lots of hospitals is qualifying patients for skilled care, and it always is certainly questions that come up. So I'd love to take an opportunity to provide some overview and some insights related to that on our next webinar. So we'll make sure we address that, but I'd like to open it up for any questions that we have.
Lindsay, we did have a comment in the chat section regarding the dental. Denise and Mangum said, just an FYI, with their recent survey, the dental was something the surveyor specifically looked for, and theirs is addressed in the skilled note done by the provider. So just a heads up to everyone.
Yeah, no, that's good information. You never know what, was this a state survey or a CMS survey?
Denise.
Anyways, regardless, it's so interesting to hear what they tend to focus on.
We had a
what does that
survey,
entail? Just that we've addressed if they have any dental needs or not, or does that need to go on to having like a agreement with a dentist if the patient was to need work? How extensive does that need to get?
Well,
or what can I find answers? Is it all in that Appendix W?
Yeah, yep, go ahead.
I was just wondering where I can find exactly how extensive that dental needs to be.
Yeah, so in referencing the Appendix W for the critical access hospitals, it's related to your policies and procedures. So making sure that you have a policy related to if there is a dental emergency, what's the procedure? Document, whether a patient refuses treatment, how do we document that? So there's certainly the policy and procedures that are within the Appendix W. But it sounds like maybe Denise, recertifications, we had and it sounds like there's part of Denise's assessment relates to their, a dental assessment, whether they, have needs, missing teeth or, needs related to dental.
We had a state survey back in August, and they basically just looked at our policy. We had in there that we have an agreement with the Okeen dentistry in case of an emergency, and otherwise, if they don't have an emergency, it would be dealt with on an outpatient basis. And they were very pleased with that, and I'd be happy to share that policy if someone needs that.
Now, was that within your swing bed policy?
Yeah, that and our admission policy
Okay,
for the hospital, like inpatient too.
okay.
Yes, this is Casey at Hilton. I'd really like to see that policy if you don't mind.
Sure, I can send that on over.
Great.
We have a swing bed policy that addresses the dental, but with our surveyor, she specifically wanted to see how do you assess if your patient is or is not having a dental issue. So that small initial survey on the skill met her needs and made her happy.
Okay, well, that's good to know. So maybe there's opportunity for us to look at our skilled assessment and whether or not we have a little component related to dental. So note to all.
That's great to know. Yeah.
Yeah. So again, policy and procedure as well as assessment. Has some language around dental.
Were they okay with the nurses assessing that, or did that have to come from the provider? Because like we tell a hospitalist, and I mean, we can look in the mouth and stuff, but it's kind of hard to do an actual assessment, an oral assessment from
Ours is
him.
a really simple, like, do they have any dental caries, any, any missing teeth? I mean, it's a super simple, like a checkbox addresses a few areas and then the doctor notes no oral complaints or whatever. It's very, very simple. But
Is
that
it built into your EMR, or is that something you could share with us?
I think ours is built into our EMR, but it's super simple. Any dental complaints, any dental caries, and any missing teeth. I mean, very, very simple.
Okay, thank you.
Great. Any other questions? I know we're just a few minutes over, so I want to make sure that we're respectful of time. But we will be sending out the slide deck and then the examples of policies and procedures. I will also check on the activities courses if there's anything that I can find. Hopefully Laura maybe have some access to some state offerings as well. So let me know. Again, always available via email. I'll just put it in the chat here so you do have it. So if there's any other questions that do come up, again, feel free to let me know or send a message to Laura. And she's really good about contacting me. So thanks, everyone.
Thank you, Lindsay. Yes, everyone, we did record this. We will get this posted online soon, and I will get our resources sent out to everyone as soon as we receive them. And then I will send out reminders after the new year of our next upcoming webinar. So thank you all, and y'all have a great Christmas.